Thank you, Katherine, and thank you all for having me join you today on what I recall from my experience in this program being a pretty exciting moment, being able to share a tremendous amount of work that you've been doing over the last number of months. And I really appreciate this space to be coming back to you all as an alum and also to share some reflections of mine on a career in public health. So in that lovely introduction, you kind of got my name, Katherine Mackenzie. My pronouns are they, them, their. And I'm joining you today as a grateful uninvited guest on the unceded and occupied territories of the Snuneymuxw First Nation, where I live on what is now called Gabriola Island, but is a place of many names and gathering points for the Snuneymuxw since time immemorial. And I carry with me Scottish and Irish ancestry on my maternal side and Ukrainian ancestry on my paternal side. As noted, I am currently the acting senior director of overdose policy with the BC Ministry of Health. And I am also an alum of this program, having completed my MPH in 2022, where I specialized in Indigenous health studies, which does mean for those of folks doing the math, I did start in 2020, which was a fun and wild time to start a degree in public health. Before I go into my keynote address, I want to start with a bit of a caveat to you all that I'm speaking to you today, not as the Senior Director of Overdose Policy or on behalf of the Ministry of Health, but instead as an alum and as someone who has worked in public health for quite some time, and as someone who cares deeply about what a career and what a commitment to public health can offer to advancing improved well-being for the people that we know and love. So as noted, I've been quite fortunate to work in the field of public health for over 15 years, but I haven't always known to describe my work as being public health. I thought that I had a very meandering and diverse and complex career path, but I now know that, and now can joke really, that it's all cabined under one umbrella. But under that umbrella, I have worked in roles that have ranged from direct service delivery and frontline crisis response to designing, implementing, and evaluating new programs, to research roles, to leading policy transformation projects, and now, of course, working in the public service. And my career has allowed me to touch on topic areas ranging from youth programming and recreation in remote northern communities to addressing life-ending and life-altering gender-based colonial violence, to advocating for changes to the criminal, legal, and criminal punishment system, to queer and trans healthcare and rights, and of course, most recently, over the last number of years, substance use. And what draws me in and keeps me engaged in this work are the complex challenges that public health grapples with, requiring thoughtful and intersectional analyses and responses that are supported by robust evidence and knowledge frameworks. Simply put, I appreciate that this trajectory of mine and the work that I know is still to come ensures that I will never be bored. And I'm assuming for most of you, that is the same call that has brought you into this degree and brought you to this work. But I will note that because the problems we seek to address are typically so highly complex and there's systems challenges, there's a real danger that is present when we look at our work and when we look to define what success means in a way that requires, or a way that suggests that it should happen in a linear trajectory. And that's what I want to speak on today, specifically reflecting on my experience working through an ongoing public health crisis and what it means to keep advancing public health policy and good public policy in changing and challenging times. So I imagine that most of you are well aware and carry close to your hearts that just last week, BC marked a horrible anniversary of 10 years of a public health emergency due to the ongoing toxic illicit drug crisis. So this emergency was first declared on April 14th, 2016, by then Provincial Health Officer Dr. Perry Kendall following an exponential increase in drug poisoning events and death due to the increased presence of fentanyl in the drug supply. Now, following this declaration in 2016, we did see a rapid deployment of new resources and innovation across the health system and community sectors. And there were a lot of parties involved. It was no one person leading this, it was a collective effort. We saw overdose prevention services grow from having less than 10 in BC to more than 50 which now operate. Health and community partners began to operate drug checking services on an ongoing and permanent basis, whereas before they had largely been temporary and associated with music festivals and raves. We saw education resources for clinicians be developed and changes made to medication availability so that people had increased access to evidence-based medical tools like opioid agonist treatments and medications for alcohol use disorder. And perhaps most importantly, we saw communities began to rally behind calls to action to address substance use as a health issue rather than a criminal legal one. And some public sentiment research that happened between roughly 2016 and 2019 found that while general attitudes were still quite negative towards the concept of drug users, it was gradually moving towards neutrality, or towards when I say moving towards neutrality, meaning that the concept would have neither a negative or positive valence. And this might have been because people were just so shocked by what was happening and how quickly things were going from bad to worse. But we thought we were seeing changes in how people in this province were reacting to and thought about substance use. And arguably we were, but where we were in 2016 is profoundly different to where we are today in 2026. It's dangerous for us to look back and see the early years of that emergency as a sort of halcyon period. And they weren't. They were hard and heartbreaking and scary. But many of us working in this area, and I know many of you and certainly many of your faculty were deeply involved in what was happening at the time, we saw and felt a sense of collective urgency and also collective possibility. And perhaps because of that, we as a broad community responding to this crisis, we're not quite ready to respond for how quickly things could and would shift. So citing research that was recently published in 2025 by Drs. Charlesworth and Hatzenbuehler, they demonstrate just how durable stigma can be. Apologies, my dog is in the background, so if you see rustling, that's him. So just how durable stigma can be. And notably, they found that stigma against marginalized groups is often reinforced and re-entrenched as a mechanism for maintaining powerful status quos. So when unprecedented and destabilizing events occur, like, for example, a global pandemic, attitudes, beliefs, and behaviors that may have been perceived to be improving, i.e. moving towards neutrality, can rapidly reassert themselves. In fact, their research specifically notes that attitudes towards people who use drugs, or in their published work, addicts, was among some of the most negative and harmful for all health conditions, and that it has been so for over a century, which might have been helpful to know in 2019. Because when I look back at what has changed over the years as BC continues to grapple with this toxic drug crisis, and not just BC, but many jurisdictions, I see how from 2020 on, increasing social crises have perhaps led to a reinvigoration of anti-drug user and anti-harm reduction rhetoric and actions. More specifically, I have seen how an emerging discourse under the guise of community safety or public disorder have contributed to both explicit and implicit narratives that place the burden of collective unease on the backs of people who use drugs. Not on poverty, not on a lack of access to material necessities like housing, and not on the existential threats of climate devastation and war. And instead of seeing how substance use may also be a response, a perfectly logical response to these stressors, it is instead positioned as the sole cause of social angst. Or more specifically, I should say, the people who are using substances are. And within that group, we know that these consequences are not experienced equitably. There are distinct racial and class-based biases that position some people under that category of drug users and others with a unique privilege of just being someone who may use drugs on occasion. Now, obviously, this logic suggests that if we could just solve this pesky problem of substance use, then all those other stressors would disappear. But I think we know it's not that simple. And it's this shift, this rhetorical discursive shift, this practice-based and lived reality shift over the past few years that I've been reflecting on quite a lot recently. Not only because I can be honest, I didn't imagine that we'd be here when I began working in this subject area around 2019 specifically, though I had been working adjacent to the crisis since 2016. But also because I see how important being aware of this vulnerability is and how I approach my work, not only as a professional, but also as a community member, as someone who loves people who use drugs, and as someone who has lost people to the toxic drug crisis. And I see how important it is to understanding that what we are being asked to address from the public health side is not just the toxic drug crisis, but the pervasive belief system that serves to operate and uphold a status quo through the villainization of people who use drugs. Something, to be blunt, that service improvements alone probably won't and can't touch. All of this might sound like a bit of a bleak outlook, and I think I've been a little bit doom and gloom to you all on a Thursday morning, but I retain quite a lot of hope, or at least a stubborn determination and optimism, because as much as progress may not be linear, neither are reactionary movements permanent. And while the ongoing toxic drug crisis remains a political lightning rod across jurisdictions, good work is happening, and I know you all see it. We have learned tremendously across this past decade. Services that were once considered to only be part of an emergency response are now being integrated as core and permanent supports for people who use drugs. And communities continue to mobilize and innovate to keep themselves and each other as safe as possible through approaches like peer-based witnessing, system navigation supports, and education, no matter what bureaucratic systems may or may not do. And as public health professionals, what this decade of learning asks of us, in my opinion, at least in part, is to consider how our approaches that allow us to consider those approaches that will allow us to be more proactive in addressing the durability of bias from the outset and not presuming that they will change as an effect of other good work. More specifically, I wonder and imagine how we can continue to push forward on the best available evidence while also moving to close the door on reactionary redirection. For example, when we are looking at novel approaches and innovation, that we also take the time to build out the back-end supports, whether that be policy or through regulation or through monitoring and evaluation approaches, so that if and when things start to change, our responses are not predicated on goodwill. And I ask myself, how can we be proactive in our communication approaches to avoid creating narrative voids that otherwise get filled with mis and disinformation? I'll close by again citing the work of Dr. Charlesworth, who has, through her course of research, shown empirically that while change is far from linear, and the enduring legacies of biases and stigma are reinforced by powerful hegemonies, change can and change does happen at a population level. So while relying on the best available evidence and empathy alone may not make enduring change, applying a comprehensive, diverse, and multifactorial strategy and reinforcing systems responses can have lasting impacts. And while the toxic drug crisis may be a somewhat extreme example of how complex this can be, none of what we are ever asked to consider in public health work is simple. I joke with my staff often that if the answers to these problems were simple, we would have solved them. We would have solved them in the first year. We would have solved them before it became a crisis. But we stay on this work because it matters and because I care deeply about it. We all do. And I know that's why you are here. Many of you have experience in working in public health and may have sought out this degree as a way of enhancing your practice. Others might have been just curious about what the hell public health is and be brought into this exciting knowledge and like theoretical framework that a public health practice can offer you. And it makes me excited to think about what might still be possible, even when things are hard. And it makes me excited to do the work alongside some really incredible people who also care deeply about this. People who see the challenges we have to navigate and ask, well, what can we try next? And be ready to keep trying. Thanks.
Thank you so much, Katherine, for those words of hope and despair.
That's how I feel most days, y'all. Like it's a fun career.
I think we can all acknowledge that, particularly with the toxic drug supply poisoning, there have been many moments of despair, but also so many moments of hope, as you spoke to, the community rallying around. And there has been some change in attitudes and perspectives, although it's a bit of a pendulum, isn't it? Anyway, I would now, with your permission, Katherine, like to open it up and see if there are questions from the audience. As you said, there are many people who are passionate about this issue and other social justice issues. I'm scanning the crowd. Is there anyone who would like to start the questions? Well, people are thinking maybe I can seed one for you. So I guess thinking about some of those, I think you called them the back end initiatives. Can you give us an example? It doesn't have to be from current practice if you're not able to speak to those, but an example. Yes.
Yeah, absolutely. So I think one of the things that I can draw from, like years ago in my career was as I mentioned, in previous roles, I worked on reforms to the criminal legal and criminal punishment system. And one of the things, quite bluntly, that I'll say is I worked on changes and on advancing changes to policing practice, and specifically on how police could and should respond in the event of a person being declared missing by their loved ones. And so what came forward was a directive on here are the steps that you need to take. That's step A, step B, step C. You need to respond accordingly. You need to assign resources. If they meet these criteria, then you need to kind of ramp up the response, which was good work. It was based in evidence. But what we didn't do at the time, and I think we might have all seen some of the consequences of this, was put in a framework to create accountability structures if police did not do those things. So it was all very well and good to say you should, you must, you can, you have to. But because there was no kind of back end resourcing or back end consideration of like, well, what if no? What if an officer or an agency decides to not do this? There was no mechanism to ensure that and to advance this more meaningfully. So even though we were like, oh, this is great, this is work that is setting a standard, setting an expectation, it ended up being something without teeth. And as times change, this was many, many years ago, we have seen that goodwill, that enthusiasm for uptake on a particular approach to addressing missing persons, vulnerable missing persons, hasn't necessarily been equally applied across all policing apparatus. And so that's a very specific example that I think is quite publicly known, but is something that I think of a lot as like, how do we build in accountability, or how do we look at the dispositive example of something where we're telling a system, hey, you should do this or you must do this? How do we build in that back end component where it's like, and if you don't, if this doesn't happen, here's the consequence. Here's the accountability. Here's how the public can respond to you.
Thank you. That's a great example. Other questions? Sean.
Morning, and thanks very much for the talk and for the work that you do. I'm based in Ontario, and we're losing all of our supervised consumption sites in a matter of weeks. So I had a question about conveying evidence to the policy level, good stories to the policy level. I know sometimes good stories and evidence aren't enough, but any advice from a distance, because being embroiled in it here, it can be hard to see the forest for the trees. From a distance, if there's any advice for trying to bring evidence and elevate evidence up to a policy level, and any advice for trying to create robust and sustainable practices that might be more robust and resilient to political change and political will.
Yeah, I mean, Sean, first off, I'm so sorry. As soon as you mentioned that you were based in Ontario, my heart just broke because, of course, we're all watching what's been happening and the way that observed consumption services have really been villainized. So I think this is a classic example of what I was talking to, of like how harm reduction services become the political boogeyman, even though the evidence, of course, doesn't support that. Somewhat, maybe overly bluntly and direct, I think one of the strategies in situations like that is ensuring that I have tried and failed across my career on conveying policy change or advocating for change on the basis of it being good evidence and ethical practice, because that doesn't always work. So what I would say in situations like that, and it's not dissimilar to situations that we're dealing with here in BC, is to instead flip the narrative and show how the loss of these services or this particular policy approach is actually really bad for you. Because if you want to talk about, public disorder or litter or any of these things, well, let me tell you, OPS and SCS, they're associated with a decrease in neighborhood crime. They're associated with decreases in litter because you've got pickup and cleanup crew. You're associated with decreased public drug use. So instead you try and reframe the narrative rather than trying to bring people over to your side. You bring and kind of manipulate, to be blunt, the evidence while still being true to it, to address the policy problem that they see. So if the policy problem that they're describing is something like, well, we don't like public drug use, then you say, great, I have an option for you. There's this thing that keeps people out of public. Because I think that where I think all of us that have a public health grounding, we know that there's no resolution that leads to people not using drugs. But I think that's often where politicians are trying to get to. It's like, well, if we just close these services, then people will stop using drugs. And we know that that's not the case. So instead you position it, well, if you close these services, then you'll have increased crime. If you close these services, then you'll have this. And these are the things that you actually care about, at least in press. So here's how you do it. Are you going to win? No, not all the time. But I have found that it's a much more effective strategy. But it's really, truly, my heart goes out to you and your colleagues in Ontario, because I know that there's a lot of excellent work and incredible community-led organizations that are being impacted by this and are ultimately going to have to close.
Thanks, Catherine. Sandra, you are next.
Hello. I'm hoping my mic works. Is my mic working?
Yes,
we can hear you just fine. Yep.
The video wasn't, so I was concerned. First of all, thank you so much for everything you've been sharing today, Catherine. I'm sitting here with my sister, and we're both deeply, deeply enjoying and learning and discussing and kind of talking over you and then going, shh. But so my question, and I don't know how much you may be able to speak to it, but in BC here with the, what I noticed with the decriminalization policies, because I'm in northern BC, I'm in Prince George, and I mean, not that it was just Prince George, but the immediate municipal response with the bylaws that essentially made it very difficult for decriminalization to be actualized what would be a takeaway or a lesson learned from that? Like hindsight's 2020, if you had a time machine, and not in like you need to fix it or anything, but like it shocked me. And it was just such an interesting lesson in the different levels of government and all these different responses. So I'm just curious if there was something you would do differently or would have a lesson for us new grads as we change the world. I would just love any thoughts you have.
Yeah, absolutely. So I've got to be careful here, but as I said, I'm speaking as a private citizen, not as a staff at the Ministry of Health. Blah blah blah. Caveat, caveat, caveat. I will say, Sandra, thank you for the question. This is kind of what I was alluding to somewhat when I spoke to the need for strategic communication being embedded in our work from the outset. Because I worry that some of the challenges that the public writ large might have had with things like decriminalization and the exemption was not having a clear understanding of what it was and what it was supposed to be and what it was supposed to achieve. And that is no one person's fault. I think that there were comments made by political leadership at the time that implied that, with decriminalization, we'd see less death. And no, decrim wasn't going to lead to that. It was about how people who use drugs would not be incarcerated or punished by a criminal legal system and might be more inclined to access services, which, yes, down the line could result in reduced death, but it wasn't going to be a one-to-one relationship. And so when that didn't happen, if that was the expectation that people were inadvertently getting from a communication standpoint, when that didn't happen, kind of out of the gate, decrim was positioned to fail in some ways, because all of a sudden communities are saying, well, hold on, we've done decrim, but people are still dying. I'm still seeing all of these uncomfortable things that I don't like about people who use drugs in my community. And because it didn't fix it, I am opposed to it. And so I think as a takeaway for myself and for many of my colleagues in government and outside of government, it's been, okay, how do we ensure that from the get-go, the public is brought along with us, things are clearly communicated around expectations, and if there are political narratives that are happening at some other level, whether it be municipal or a regional district or federal or provincial, that there is a consistent public narrative about this health approach that people can turn back to and go, yeah, but what about this thing that I've heard over here? What about this? Just something to challenge that. And we didn't necessarily have that. So there was a void created, mis and disinformation filled it. And we saw that for all that there were successes of the decrim exemption, there were also significant challenges and a lot of reactionary pushback, which I think leads to where we are today.
Thank you. Thank you.
Over to you for the final question.
Thank you. Thank you so much, Catherine. I get one just question. I think like leaving this program, we don't always know where we're going to end up, and being in provincial government, I think just like curious how you like stay well in the work and like navigate being in those top-down systems or bureaucracies, or being maybe like entrenched in those systems where things might feel unethical sometimes or not always aligned, and how we like stay steadfast in our hearts in this work and navigate that, if that is a path that we take.
That is a beautiful question. Thank you so much. I joke, somewhat cheekily, but also truthfully, that when I first joined the public service, I had just finished grad school out in Ontario. I was moving back to BC. There was a job that kind of aligned with what I wanted to do. So I took it and I said, okay, Catherine, you'll be in the public service for 1 year. You'll get a salary, and then you'll get the hell out and back into the community sector, which is where you belong. And it's been 10. So obviously that didn't happen. And I think because what I found in this career is that as challenging as things are, there are these pockets of really exciting opportunities. So I will say, like when I started working in what was then the Ministry of Mental Health and Addictions, this was about 3 years into my public service career, there were two things that we were told we were never going to do. We were never going to do safe supply, and we were never going to do decriminalization of drugs. And a couple of years later, we did both of those things. Now, obviously, things have changed since then. But it's those moments of getting to work on these kind of incredible generational policy shifts, these experimental approaches and these systems-driven approaches that I think keeps my heart full even when it's breaking, because I see continual possibility. But I also will say a really important thing is knowing where your lines in the sand are. There are certain things that if I were asked to do as a public servant, or I would ask to do in any job, I'm just currently employed in the public service, I would not. There are certain things that I think I cannot find an ethical kind of rationale for it. And knowing where those lines in the sand are, I think, is a really important part of longevity in these types of jobs, because that's where you know you're not going to compromise your soul and compromise your heart so much that you can't do it any longer. And I also know that the key thing for me is that the moment that I feel like I need to numb out to keep in a job is the moment I need to walk away, because at that point I'm doing more harm than good. Because we shouldn't be numb. My job is responding to a crisis that has stolen 18,000 lives and counting. I need to carry that with me every single day. But because I carry that, it's not when I say I carry that with me, it is not that it's that it is leaden. It is a call to action for me. It's 18,000 lives. I refuse to see a further 18,000 more stolen without me doing something about it. And if this is a place where I think that with a degree in public health, with the career trajectory that I have, I can try and turn the dial, even small adjustments can be impactful. So I think it's that. And the other thing, I know it's really kind of cheesy to say, but make sure if you're anywhere you go, but especially in the public service, it's a huge bureaucracy. Make sure you like the people that you work with. I'm fortunate. I work with some really beautiful people. I actually work with a number of alums from this program as well in different health authorities, and it's hilarious. We work quite closely together. So working with beautiful people and working with people who really care is a continual reinvigoration for me. It keeps me coming every single day.
Thank you so much, Katherine. That was an amazing talk, full of wise words and inspiration and heart. And we appreciate all that you do. And you're getting lots of love from the Zoom chat. We've also had a request, and I believe you've mentioned a few studies, but in particular the Charlesworth papers. We've had a request in the chat. If you could please share those resources, I think people would really appreciate it. So Absolutely. This is great. Spreading the knowledge around is awesome.
I love introducing theoretical frameworks that might be helpful. Absolutely. On that note, Katherine, I can send them to you, Heather? We've been corresponding on email, and then you can circulate. Okay. Thank you.
That's perfect. Yes. So again, thank you so much. I know you're super busy. You've sandwiched us in between meetings. We so appreciate the talk and the work that you do. And, go in peace. Go in peace.
Thank you. Thank you all so much for including me. And just a quick final pitch. If you're ever curious about a career in the public service, please reach out. My email is katherine.mackenzie@gov.bc.ca. You can also find it on the government directory. And I'm always happy to chat with fellow MPHs. So please don't hesitate. And thank you all so much for including me today. Congratulations.
Thank you, Katherine.